Today on Inside the Issues, I speak with Dr. Corinne Squire about her new book, Living with HIV and ARVs, 3-Letter Lives. Hello and welcome to this week's edition of Inside the Issues, a CIGI online podcast. My name is Dr. Andrew Thompson. I'm an adjunct assistant professor of political science at the University of Waterloo and program officer at the Balsley School of International Affairs. Every week on the program, we're joined by an expert in international public policy, global governance, or some other aspect of global affairs. Today our guest is Dr. Corinne Squire. Dr. Squire is a professor of social sciences and co-director of the Centre for Narrative Research at the University of East London in the United Kingdom. She's here today to talk about her new book, Living with HIV and ARVs, 3-Letter Lives. Welcome to the program.
Thank you.
So what inspired you to write the book?
So a few things really. I think the first thing was that there's a very obvious kind of contradiction presently in the pandemic between some very positive aspects, for instance, expansion of treatment to about 60% of people who need antiretrovirals among the 35 million people living with HIV. So that's a massive expansion actually over the past 5 years, and partly has happened under the auspices of Millennium Development Goal 6, which was to halt and start to reverse the HIV pandemic by 2015. So that's an incredibly positive aspect. At the same time, levels of new infections are generally reduced, especially in high prevalence areas of the world. Deaths from HIV-related illness are reduced, partly because of the expansion, of course, of antiretroviral treatment. Stigma and discrimination in some places are reported to be on the wane, and I think there's been a general political and policy will to work together in many different sectors around MDG 6 and to create what's often called an AIDS-free generation, or a future without AIDS, or these kinds of positive frames of the future. At the same time, there are a lot of negative aspects of the pandemic still continuing, and that's the tension that's interesting for me. So for instance, half of the people living with HIV don't know their status in the world. People who have antiretrovirals are still only 60% of those who need them on the most conservative estimates of need, actually. On more recent World Health Organization estimates of need, it's about 34%. Despite reductions in stigma and discrimination, there is still a lot of reported stigma and discrimination for people living with HIV, whether or not they have access to treatment. The medical benefits of antiretrovirals are immense, but there are still problems with them, and long-term problems with them. Guaranteeing the funding for them is a major future issue. So there are many, many difficult issues still to contend with. At the same time, also interesting is that we're in some ways a new era of issues around HIV, in that now those 35 million people are all looking at near normal lifespans if they get access to antiretrovirals. So they're looking at, HIV as a chronic illness. Sometimes some people say even just a long-term condition. And many attendant issues come with that around different health problems that may arise later in people's lives living with HIV and antiretrovirals, for instance, cardiovascular disease, diabetes, and so on. But that's a whole new perspective for people who are diagnosed now. For instance, very often HIV will be less of an issue for them than other pressing concerns like food security, like migration and citizenship status. So those are new phenomena in a way. The place of HIV is really one of many issues in people's lives given treatment, and the long-term issues around treatment. And some kind of forgotten issues also exist, I think, which are, for me, the long-term impact of people having lost a lot of significant people in their lives during the epidemic. And I think this kind of history of the epidemic and the history of stigma and the history of discrimination and so on tend to be overlooked in contemporary optimism about HIV. And then the other impetus for me to do this work was that I've worked for a long time doing interviews with people about their strategies for living with HIV, what support they use and want. And I've done that in the UK and in South Africa. And so every so often I go back and kind of check with people how things are going. So when I did this in 2010 in the UK and did some pilot follow-ups with people who've been in the study for a long time, in fact, in some cases since '93, what was very notable for me was, in fact, how the kind of medical problems were continuing for them. Issues of stigma and discrimination was continuing. Many people felt that in the UK the epidemic had become invisibilized. And these were major, in some ways, new issues, given that people's approach now seemed much less, I would say, entitled than maybe 10 years ago, when HIV activism was perhaps a stronger force. So people very often framed their approach to these continuing issues within a discourse of gratitude, really, and also within the contemporary cuts discourse, I would say. So people were very affected by contemporary austerity measures and really had taken them on themselves and felt very strongly that they couldn't be asking for more in certain areas, even though they were reporting quite stringent cuts, particularly in psychosocial services. So, and that was something I wasn't expecting to hear when I started to do these pilot re-interviews, that really I was hearing stories of austerity living more than of HIV.
Right. For the next section, I'd like to talk a bit about your methodology, which is really fascinating. So thank you very much. We will be back in a moment with Dr. Corinne Squire. You are watching or listening to Inside the Issues, a CIGI Online podcast. Look for us at cgonline.org, on Facebook, on YouTube, and on Twitter. Welcome back to the program. Corinne, throughout the book, you tell people's stories or narratives. Can you say a little bit about your methodology and the types of insights that it can help to generate?
Okay. So in this particular field, it seems quite useful to adopt a really rather open qualitative method, given that people living with HIV are very frequently the objects of other kinds of investigations where they have to tick various boxes and so on, and there may be a small amount of leeway for some qualitative input from them. And a lot of that kind of research is incredibly necessary, of course. But it tends to focus in the psychosocial arena on factors that may be affecting their medical adherence, how they're dealing with prevention issues, transmission issues, and so on. So to give people in that particular field a more open arena for talking about their lives often seems quite useful. It was particularly important, I think, when I started research in South Africa in 2001, where at that point the epidemic was really politically as well as socially silenced and treated as something that perhaps didn't exist. So in that context, the opportunity to talk freely about yourself was really quite a political one in some ways, for some people anyway. And many people were very concerned that those tapes would be kept and the records would be kept. So, you know, any of those kinds of ethical strictures that would advise one to get rid of data after a certain period of time would have been met very negatively by the interviewees at that point. So that's within the particular HIV context that I think it's quite useful. More generally, to take this kind of narrative approach, I think gives people a length of time to talk within which a lot of contradictions and difficulties can come up that wouldn't if one was doing this in a more kind of segmented way, if one was researching in a more segmented way, going topic by topic, for instance. And in the HIV case, that's very useful because quite often people start off with what Paul Farmer has called, you know, a kind of epidemic of gratitude around what services they've had. And it's only later on that one hears of the kinds of problems that people might be experiencing. And those are the problems, in fact, that one needs to know about so that you can plan future policy to take those into account. You know, why aren't people taking up antiretrovirals, for instance? It's a very key issue. Particularly men take up antiretroviral provision much less than women do. And it's really important to talk to women and men about what their understandings of antiretrovirals might be, and do that at length in order for some of the difficulties to emerge. And quite often, at the same time, one gets stories told by people at really a number of different levels. So that's another aspect of narrative work that's quite useful, that you can hear personal stories alongside people drawing on cultural narratives, on the political narratives that surround them, and on the interpersonal and microsocial narratives around them. So it's a good technology, if you like, for understanding the different forms of representation that converge in the life of somebody who's HIV positive. And then I think finally, this is not always the case, but there has been around HIV and around other silenced intimate conditions quite often a strong usefulness of personal narratives in bringing people together, in articulating common understandings of a privatized condition, and then being able to use those common understandings to educate others and to push for certain kinds of changes. And that was very important in the HIV epidemic in early days, in the US initially, for instance, with ACT UP, in the UK with the Terence Higgins Trust, in more recent times in South Africa, the Treatment Action Campaign also is very aware of the significance of personal stories for building those kinds of common understandings and common commitments to action.
Right. Now, you interviewed people in both the United Kingdom and South Africa. Why are these two locations interesting to compare or to contrast?
Right. So partly because I had history of working in both those places, asking rather the same kinds of questions so that I could go back to interviewees, and it's also helpful to have that kind of quasi-longitudinal aspect in a study, because one then can see, snapshots of the epidemic at different times. But more generally, why the UK and South Africa? Well, it's very helpful to have a medium income and a high income country together in a study like this. These are both countries where one could say people live with antiretrovirals as well as HIV on a fairly universal basis. That is, both countries have reached now what is defined as universal provision, that is, provision that's accessible to 80% of people in the country. South Africa also has a wide structure of social grant provision. It has pensions, unemployment benefit for some, disability benefit, child allowances. It's made big changes in provision around HIV, and in particular there have been now in South Africa people taking antiretrovirals for 10 or more years, so that the kind of long-term issues of living with HIV and ARVs are converging in some ways despite the massive resource differences. And it's important to note also that both countries have high Gini coefficients. So,
right.
In the UK, there are people living, especially migrants and asylum seekers,
Sure.
living in extremely resource-constrained circumstances with much the same food security issues as you might find in some South African contexts.
Was there anything in the stories that surprised you or shocked you?
I think the one of the things was what I mentioned earlier, was this kind of shift from the early 2000s when people talked with much more strong sense of entitlement, I think, especially in the UK. That was quite surprising. I think the effects of recession were very well, maybe not surprising, but quite shocking really in the way that they impacted in both countries, largely around the reduction in psychosocial services. So, increasing levels of isolation and depression for people, because of explicitly related to them to the closure of support groups or services that made support groups accessible to them. For instance, minibuses or something like this in South Africa. And those cuts also have very kind of pragmatic effects on, what medications are available to people. In the UK, pharmacists were telling people the prices of their medications in ways that were very, I guess you might say, prescriptive. In South Africa, people were very aware that certain lines of medication would not be available to them. And also people trying to build their income in South Africa through income generation projects had often lost markets through the recession.
Right. Thank you very much. In the next section, I'd like to talk about some of your research findings or research conclusions. You've been watching Inside the Issues, a CIGI Online podcast. Look for us at cgionline.org, on Facebook, on YouTube, and on Twitter. Welcome back to the program. Corinne, in the book you talk about how HIV, or how there's a distinction with HIV between its exceptionalism and its particularity. What do you mean by that?
Well, there's been a long debate about what's called exceptionalism, critically, around HIV, in which critics of this approach to HIV suggest that it's no longer, if it ever was, useful or necessary to treat HIV as an exceptional condition. This happened, one might say, because of its early and very rapid expansion in prevalence in some areas, its fatality, its medical resistance and difficulty, recalcitrance one could say, the levels of socially freighted meanings around it that generated large bodies of stigma. And also the kind of the sense that it was going to have very widespread kind of ripple effects on countries, that it was going to destabilize countries really. And many people now suggest that, particularly because of the medical advances in addressing HIV and falling rates of new infections and general higher awareness, reducing stigma and so on, it's no longer productive to think about HIV in that way, if it ever was, and it's more productive to mainstream it, one might say, within health provision, within education, to treat it as another chronic illness alongside other chronic illnesses, to test for it within general primary care. And this is, a very a productive way of thinking, I think, in many ways, but it can, like many mainstreaming projects, it can ignore the particularities of what's happening with HIV, the continuing medical difficulties that people experience, continuing aspects of stigma that I don't think are just best dealt with by de-emphasizing stigma in public discourse. And I think that this was often said by interviewees, in fact, that they said, let me not hear one more time that it's just like diabetes, because really it's not just like diabetes. And so I think this is not only true for HIV, it might well be true for diabetes as well, but that to roll these things into constructs like chronic illness or long-term conditions, while there can be incredibly important normalizing effects of this kind of work, can also ignore some really important particularities that, if you ignore them, then become large problems.
Right. And building on that, you describe a process of naturalization, which contains three components: medicalization, normalization, and then marketization. Can you say a little bit about this process, and then also talk about some of the resistance to this process of naturalization? Sure.
So I use this term drawing from Bourdieu's and Foucault's accounts of naturalization, really, to talk about phenomena that many others have talked about, that is the medicalization and normalization of the HIV epidemic. But I also talked about its contemporary marketization. And I thought this was a kind of useful portmanteau term, naturalization, because it conveys something of the, which is both good and difficult about the contemporary orientation, many contemporary orientations towards HIV, which is that it's become, in many policy ways, I think, part of the natural order. It's expected that countries address HIV within their planning, within their budgets. That's great. It's no longer something so exceptional that one has to make special budgets or special provisions each year or anything like this. But that kind of incorporation can also solidify and become a kind of unquestioned common sense about what's going on. And that's what I really wanted to address by taking apart medicalization, normalization, and marketization a little bit. So in the arena of medicalization, what I'm talking about here is the vast successes, actually, of medical approaches to HIV, which have been really amazing in the area of antiretrovirals, for treatment, for prevention of transmission to children from pregnant mothers who are positive. And then more recently, the extension of antiretrovirals, kind of sphere of influence, I guess, has started to be felt in prevention issues. So treatment is now often characterized as also a prevention initiative, kind of at the population level. So if you treat people to a high level, if you treat maybe people so that they are really very low in viral load consistently, then they're not going to be very infectious if they do, by chance, have unprotected sex. So this is one possible way of adding on to other social and behavioral transmission reduction measures and other medical transmission reduction measures like male circumcision and microbicides and predominantly. So that's a real new area that a lot of people are very optimistic about medically. Another area is using antiretrovirals prophylactically, particularly for people who are not positive. So that people who are not positive but who cannot reasonably guarantee or negotiate safer sex for themselves may be given antiretrovirals in order to keep them negative. So that's a positive, but so far fairly under-researched, necessarily, aspect of medical issues. And it can be that this expansion of medicalization, I think, produces for people living with HIV a sense that only medical solutions are the ones that can be considered, so that they find it difficult, in fact, when they go to their doctors to talk about any other issues they have, if their viral load is good and their CD4 count is high, it almost makes no sense to talk about your depression or your isolation. And at the same time, that kind of medicalization can make it difficult even to talk about medical problems that are not treatable, perhaps, that are recalcitrant, that are not to do with viral load and CD4 count.
Great. Thank you so much. I want to come back in the last section and talk about some of the policy implications of your research. Thank you very much for watching. We'll be back in a moment with Dr. Corinne Squire. You are watching or listening to Inside the Issues, a CIGI Online podcast. Look for us at cgionline.org, on Facebook, on YouTube, and on Twitter. Welcome back to the program. Corinne, I wonder if we could pick up on this issue of resistance and then consider what some of the policy implications might be of your findings.
Thanks. So in terms of the naturalized status of the pandemic and the different processes really that feed into that, one can also see those processes kind of undoing themselves, because the medicalization of the epidemic is clearly not a solution. And people living with HIV themselves contribute, I think, very strongly to that undoing, because very often in the interview studies that I've done, one finds that their medical knowledge and actions are actually a kind of activist knowledge and actions that have come from activist filters of that medical knowledge. And those are the filters that a lot of times people rely on. And at the same time, of course, many medical practitioners within the HIV field have themselves quite strong activist orientation. So it's not simply that there's a separation between the medical and the activist, or the medical and the interest group of people living with HIV. There's a lot of interaction. In addition, I think very strongly in the current cuts context, I could hear people talking about medical care really as holistic care, and making this a very strong counteracting formulation to the medical care that they were often getting now, which they said was care by numbers in a very short period of time. So this was a very positive reframing that they did. They always pointed out doctors that provided that kind of care, and they were quite critical of doctors that counted their viral load and their CD4 counts and then said fine and showed them the door. So that was a positive thing to find. And I think also in the areas of normalization and marketization, I could also hear interviewees very strongly contesting the assimilation of HIV to other conditions, and in the area of the market, contesting the idea that marketized solutions were really even a market sensible approach to HIV issues.
Right. So, building on that, then, are there specific policy recommendations or policy implications that we can take from your findings?
Well, yeah, I think there are some. Probably others could draw more from the work. Firstly, around medical approaches, that these have to be these clearly have to be funded, and where funding is unstable for market reasons, particularly around the financial crisis, that's not just a small blip in someone's medication. You know, that's a really serious life-threatening problem with antiretrovirals. So that has to be seen in rather a different context than simply a small, yearly cut to funding budgets or whatever. One really interesting aspect of provision that hasn't much been explored, although it's increasingly being implemented, is countries that are heavily HIV affected making their own antiretrovirals. And that's often promoted, but within a market frame it can be difficult because those medications may not be the most competitive ones on the world market, yet it may be very important for those countries to be involved in producing them. Another policy element I think that's very obvious from what I've already said is that psychosocial services are really cheap but first to be cut.
Right. And
also just incredibly important for pragmatically in terms of keeping people's health going and good, but also in more general circumstances. And then in the area of the kinds of market supports that people need for living with HIV, in many countries now which do provide grants for people who are HIV positive if they're disabled, those grants are withdrawn if their health is good. But health is very fluctuating if you're living with HIV, even if you're well treated. And also in countries like South Africa, high unemployment makes it very unlikely that you can go into paid work. So people in those circumstances are really in a difficult place. You know, they lose their disability grant the healthier they get. They also lose food support, and that's been a very common trend. I think many people in South Africa reported this, that food support had been lost. And food is very necessary for taking antiretrovirals. And there are many policy arenas that one could think of addressing here. I mean, there are already some good studies on social cash transfers and how those affect people living with HIV and people who may become positive and reduce their risk. There are campaigns in South Africa for basic income grants, for instance, that look to me really useful campaigns in this respect. There are just kind of food initiatives that could be taken around collective purchase and community cooking and things like this that people could be doing, that could be taken up more broadly. I mean, it's unrealistic really to talk about sustainability and investment in the HIV context in a narrow way, and I think a lot of funders want to do that. They want to provide an investment and see the outcome in a one-off kind of way, and they want sustainability quickly. They want an urban food garden to be, feeding the community quickly, or they want to phase out food parcels and all this kind of thing. It's really understandable, but it doesn't take into account the deeper complexities of the pandemic.
Right. So just to wrap up, is an AIDS-free generation in fact possible?
So yes, I think it's perhaps AIDS-free is a dramatic term. I mean, there are of course always for a long time going to be people who become HIV positive, at least until there's effective vaccine or cure. There are also going to be people who, for various reasons, don't access antiretrovirals and who develop AIDS and who die. So to say AIDS-free is a very dramatic thing. But it's notable, I think, that many of the interviewees that I was working with do have strong hopes for the future. They have strong fears as well, particularly around the reduction of international funding. But they have strong hopes in terms of cure, perhaps hopes greater than you would hear doctors articulate. And they also have very strong hopes and plans and local implementations of what one might call social cure. That is, that they become themselves resources in the pandemic, and they cast themselves in that way. They talk to others about HIV. They actually talk to others about what they've learned about nutrition and exercise and gender issues, abuse, all these things. They become, in some ways, local experts on these issues through their HIV education, through living through the pandemic. So I think in those ways, one can say that people living with HIV themselves are part of this AIDS-free generation because of the way that they are developing as the resourcefulness for themselves, but also resourcefulness for their communities.
This has been absolutely fascinating. Thank you so much for joining us on the show. And thank you to our audience. Please join us again for another episode of Inside the Issues, a CIGI Online podcast. Look for us at cgonline.org, on Facebook, on YouTube, and on Twitter.
The HIV pandemic by 2015. So that's an incredibly positive aspect. At the same time, levels of new infections are generally reduced, especially in high prevalence areas of the world. Deaths from HIV-related illness are reduced, partly because of the expansion, of course, of antiretroviral treatment. Stigma and discrimination in some places are reported to be on the wane. And
I'm an adjunct assistant professor of political science at the University of Waterloo and program officer at the Balsley School of International Affairs. Every week on the program, we're joined by an expert in international public policy, global governance, or some other aspect of global affairs. Today our guest is Dr. Corinne Squire. Dr. Squire is a professor of social sciences and co-director of the Centre for Narrative Research at the University of East London in the United Kingdom. She's here today to talk about her new book, Living with HIV and ARVs, 3-Letter Lives. Welcome to the program.
thank you.
So what inspired you to write the book?
So a few things, really. I think the first thing was that there's a very obvious kind of contradiction presently in the pandemic between some very positive aspects, for instance, expansion of treatment to about 60% of people who need antiretrovirals among the 35 million people living with HIV. So that's a massive expansion actually over the past 5 years, and partly has happened under the auspices of Millennium Development Goal 6, which was to halt and start to reverse. I think there's been a general political and policy will to work together in many different sectors around MDG 6 and to create what's often called an AIDS-free generation, or a future without AIDS, or these kinds of positive frames of the future. At the same time, there are a lot of negative aspects of the pandemic still continuing, and that's the tension that's interesting for me. So for instance, half of the people living with HIV don't know their status in the world.
Today on Inside the Issues, I speak with Dr. Corinne Squire about her new book, Living with HIV and ARVs, 3-Letter Lives. Hello and welcome to this week's edition of Inside the Issues, a CIGI Online podcast. My name is Dr. Andrew Thompson.